then definitely pharmacology, and then the radiology. So this will be like combination of all. And again, like last time, the way you were diagnosing that whether the consolidation is in the upper lobe or in the middle lobe or it is in the lower lobe, same way today you'll be learning something. Again, there are 7-8 exercises. 9. Start just. On to the respiratory system part. Okay, I'll just see that. Okay, coming back to this respiratory system part 7. Today's topic, it is like an independent topic. So even someone has even missed all the sessions right from the beginning till then also there won't be any problem. So starting with standard diagram, because this is the diagram which we this is left atrium, left ventricle, that's the mitral valve. From here there is the aorta, right? And then from aorta we'll be adding something else. And that is capillary bed. Right? That is a capillary which are over. Because these are the capillaries which will be giving oxygen. So that's the tissue, right? So let's say this is muscle, but basically it is the tissue. So oxygen will be given to them. Carbon dioxide will be taken from them. So CO2 will be taken from them. And from this point onwards, these are all veins. So veins, they will be from superior vena cava, inferior vena cava, superior vena cava, inferior vena cava. In short, the carbon dioxide blood from the body that is taken, moved on to through the tricuspid all the way to this is the pulmonary trunk. Right? Later it becomes artery, right and left, and it goes to lungs. Again in lungs, we'll be drawing like this. So this is what this is pulmonary, right? Pulmonary. So here, so oxygen will be picked up, and carbon dioxide will be given out. And then again, this fresh blood will start its journey and via pulmonary veins, it will be landing into left atrium and the circulation will continue. So now you have seen two systems. If you really look at this part, that there is one system which is starting from left ventricle and it is ending onto the right atrium. It is ending on atrium. And then from right ventricle, there is a system which is related to lungs and then it ends on the left atrium. So this is what will mean. The system in which the aorta is involved and the vena cavas. Right over here, there will be vena cava, superior vena cava. So that is what is called as the systemic circulation. It's called as systemic circulation. So whenever we take any of the blood pressure, so on one side there is the aorta, and on other side these are vena cavas, right? Superior vena cava. So aorta, so this will be from left ventricle And these vena cavas, they will be ending. This is what is called as the systemic circulation. So that is systemic circulation. This systemic circulation has to work very hard. It has to supply the blood to everyone, right from the head to toe. So that's the reason when you take the blood pressure, you'll find that in this entire system, there are major changes in the blood pressure. But we start with something which we already know. And what we know, the blood pressure in the aorta, because that is the blood pressure which we really take, right? And it is divided into systolic and diastolic blood pressure. So this is what normally it has to be 120 by 80 millimeter of mercury. Right? So that on sphygmomanometer, when you take the blood pressure, so it is a 120 by 80 millimeter of mercury. Now, let's talk about this 120 by 80 millimeter of mercury. Is it too much of the pressure? Well, let's see this. 120 millimeter. So if we convert it to centimeter, so this comes to 12 centimeter. 2.5 centimeters, that equals to 1 inch. We are more comfortable in inches. This is about 5 inches, roughly. 5 inches. But this is 5 inches of mercury, Hg. This is mercury. Now the specific gravity of mercury is 13.6. So that means if you take one test tube and you fill it with water, and you take another test tube, you fill it with mercury, so the mercury would be 13.6 times heavier than the water. This is the reason mercury is used. In many of the cases, we'll find that the pressure is this much millimeter of water. Over here, it is mercury, because mercury is 13.6 times heavier. It's specific. It is what is called as the specific gravity. Specific gravity is with related to the water. So water is 1, specific gravity of this mercury is 7.6. That means, let's say, forget about the 0.6 part. So even if we just multiply 13 into 5, that comes to say 65 inches. 65 inches. 65 inches of what? Water, correct? So this means 65 inches, how much? 5.5 feet, right? So over 5.5 feet. This is the pressure. So that means if there is any cut in the aorta, right, the blood column, it will shoot to that big level. This is the pressure. Because when it is given in the form of mercury, so then we see that, okay, it is only this much, but that's because of the weight of the mercury. So this is the power. This is the power which is getting generated by the left ventricle. So no wonder that left ventricle musculature, that would be thicker. Okay, so this is 120 by 80. When we say systolic, anyway, whenever we are telling systolic, that means when it contracts, right? When it contracts. So obviously, when it contracts, the pressure will be higher. So this is on contraction. That is systolic. And when it is relaxing, so that is what is called as the diastolic. It means diastolic blood pressure, the pressure can never go below the diastolic pressure, because this is on relaxation. This is on relaxation. So when we say diastolic is 80, then this is the minimum load on the heart. Minimum load. At any point of time, this is the minimum load, because that's the pressure even when it is completely relaxed. And this is 120, and this is the maximum when it is fully contracting and with what pressure the blood is pumping further. Now you can see that whenever we look at any of the hypertensive patient, it is systolic. You have a cup of coffee, then it would increase. 80 can decrease, but this is in general for normal patient. Even in anyone. So just let me finish the talk. So in diastolic, this is on relaxation. Right? This is on relaxation. That means this is the minimal load. So when there is a hypertensive patient, and let's say you have a cup of coffee and your blood pressure becomes, let's say, 130 by 82. It's okay, not to worry much. But if someone's blood pressure is 130 by 90, so this thing is more dangerous. This is okay, it keeps on increasing, decreasing as per the activity, as per what you drink, but what you eat, right? But this one, diastolic, that's why diastolic is dangerous. Increasing the diastolic pressure means it is a constant load on heart. You can say minimum, but still more correct would be the constant load on heart. Constant load on heart. But during cardiology, when we'll be talking about cardiology, this thing will be coming into still more detail. All these are normal values. They can increase or they can decrease as per individual. So if someone, it's like, let's say your blood pressure is remaining, it happens. In many of the females will find that their blood pressure is somewhere in the range of, I would say, 100 by, say, 70. So it is good. It is fine because the body is working fine with it. But then in them, if this increases to 85, so it is a matter of concern. 120 by 80, this is a standard. But then once again, it varies from person to person. Few points here or few points there. That is the reason that we need to know that what's our blood pressure. Nowadays, the digital blood pressure measuring instruments are available very cheap. It is good to keep one instrument because you never know. And blood pressure, the way it is said that diabetes is a silent killer, so is the blood pressure. Decrease in the blood pressure is fine. It will just make one change. The brain perfusion would decrease. You immediately give salt and Nimbu Sharbat, person would be fine. But when the pressure is increased, one has to That's the reason that today we'll be talking about some of the medicines so that you understand that what you are learning has got the direct implementation in the pharmacology. And then you will never forget it. So over here, this is the blood pressure, 120 by 80 aorta, because what we use is the upper limb. Over here, when the arteries they are passing, so they are in direct continuation with the aorta, so the pressure is affected accordingly. Okay. We go slightly back. Left ventricle, when it contracts fully, right, this is the pressure 120, because he is the person who is generating this pressure because of the contraction. But what happens over here onto the capillaries? When it divides, it keeps on dividing, and then through the capillaries, so that blood pressure, when it is trying to go, its pressure is decreased. Reason? There are millions of capillaries. So when it keeps on dividing, the pressure starts getting distributed. So that's why you'll find that in capillaries, the blood pressure, the pressure that remains just 20 millimeter of mercury, 20 to 22 millimeter of mercury. That is the capillary pressure. Less, quite less. So much so that as it goes all the way to vena cava, in inferior vena cava, you'll find that there are valves. Inferior vena cava, because the blood is going from the bottom, it has to go up. So blood will try to fall because there is so very less pressure. It will try to fall. So that's why the valves are there, and they keep on supporting that blood column, and finally they jump into the right atrium. For superior vena cava, nothing like that, right? For superior vena cava, straight away blood is coming from the brain, head and neck, and jumps, drips, straight away jumps in. It reach to the right. Over here, the pressure is extremely low, right? Because these are, it is just 0 to 2 millimeter of mercury. Just this much. Such a low pressure. Such a low pressure. Then it goes on to the right ventricle. Now, our right ventricle has got some musculature. So it contracts. So that pressure, which was so low, right, it has to be low so that the blood, because if the pressure on the right atrium is more, what would happen? If the pressure in the right atrium is more, then these systems, right? Superior vena cava and inferior vena cava, they have to increase their pressure so that they can just push the blood into the right atrium. Right? So that is the reason that right atrium is kept very low. It is a very thin walled chamber, so that blood can easily, as if it is getting sucked into the heart. Then comes the valve, tricuspid valve, it pushes into right ventricle. Now right ventricle musculature comes into picture. So it generates some pressure, but not as much as the left. So some pressure is generated because it is again a thick walled but related to atrium. So over here the pressure generated is by about 25 millimeter. Diastolic is 8 millimeter. Quite increased from all the way to 25. So when it goes out into the pulmonary trunk, this is the pressure which it is taking to the lungs. And when it comes to lungs, again they divide. And so pressure into the pulmonary capillaries, it drops again. It is very much necessary to drop this pressure because this is a very delicate structure. The alveoli, because these are the regions of alveoli, correct? These are the regions of alveoli. So alveoli, so they are very weak. And it is like just a single layer of endothelium, single layer. And over here, if the blood goes and does the dadagiri, then it will break the tissue. It will literally break the tissue, right? And what would happen? This is the capillary. This is the capillary, and when the blood is coming from the right ventricle with a force, so these simple thin layer of endothelium, they won't be able to stop, and this tissue fluid that will go into the alveoli, leading to pulmonary edema. Because the pressure is so high. That's why the pressure over here is kept very, right, very. So this low pressure, so that blood innocently passes and just oxygen, carbon dioxide, gas exchange is done, and then move on. Then these are our pulmonary veins. Now these pulmonary veins, they are good. So they are having oxygen. But see, this is 2 to 7. So when they land onto the left atrium, the pressure is about that much only. And when it dilates, it is about 2 to 7 mm of mercury. That is the pressure of left atrium. Now when it contracts, so this contracts and pushes the blood into left. That left ventricle, that's why if you see, this was when we learned it in ECG, or when we learned it in the form of the electrical system from SNO, it tells that both the atria start contracting, right? They contract gradually, they are filling the blood. So there is a formation of P wave, and then this is a flat wave. Because this is the time when left atria is slowly filling the blood into the left ventricle. It is taking time, so that's why this is flat line. This is the time which is spent between SA node and AV node. Because AV node is holding the signal that let the left ventricle fill, and then I fire. So when that signal goes into the bundle of phase 2 Purkinje fibers, left ventricle contracts. So this is like you have to visualize that what is happening in this entire system. We added 2 components, right? We'll be adding 1 more component. So this is what is called as, what we wanted to emphasize was that this is the systemic circulation. Systemic circulation in which the body and the tissues, they are getting oxygen. And this is 1 more circulation. And that is what is called as the pulmonary circulation. Pulmonary circulation. Till this point, any doubt, any query? Till this point. Because we'll keep on mounting on that. I'm just highlighting all the pressures. So this is 120 by 80. That things start from here. Here, tissue capillary, it drops. Then over here, it is extremely less. Then it becomes 25 by 8. Right? So that is the case of ventricle. Over here, it's very less. Remains less till left atrium and This would be the base for our today's discussion. This will be our base. In fact, not only today's discussion, but our next two sessions will be based on it. I want to show you how pressure increases from 7 to 120 in the left. Very simple. Right, left ventricle is having very powerful musculature. Right? I'll draw it again. So what I was telling was, from respiratory system, I want to take you smoothly into the cardiology, because both these systems, they work together. So there is no fun in learning things separately. We finish the respiratory system one all the way, including the X-rays, including all the diseases. But time to time, as it would permit, we'll keep on talking about the cardiology, some of the concepts. So that when we'll start cardiology, it will be like you will be knowing almost the complete ground part, complete base, and then we'll mount up. Okay. Talking about this part. Now we take this much portion. So this is our left atrium. From here, this is having a thick musculature. And this one is our mitral valve. So it's writing M. Over here, the pressure, if it is 7 mm and all the way, it jumps on to over here to 120. Multiple reasons. One, say because of the left ventricle musculature. It is that thick, that powerful. The second reason, the sufficient time is sufficient time. That is when the left atrium starts pushing the blood into the left ventricle. So that is, it is called as the atrial depolarization. Depolarization means current has come and it is contracted. Simple. So this is our ECG. This is a P wave. This is the P wave. So P wave is because of atrial depolarization or the depolarization. So atria is contracted. But now see, there is a flat line. There is a flat line. Nothing is happening. Electronically, nothing is happening, but mechanically, so many things are happening. Mechanically, because the left atrium has contracted, so that means the blood which was present over here, it is now getting pushed. It is now getting pushed into the left ventricle. Left ventricle is getting filled. Left ventricle is getting filled. It needs time. So this is the reason that this. So electronically, what is happening in this case? Electronically speaking, we have got SA node. We have got SA node. Right? This is SA node. And then there is AV node. From SA node, it triggers the atrial contraction. It triggers the atrial contraction, and then it comes to AV node. This occurs immediately. But this AV node is not letting the signals go further. It is telling wait. So this is that wait state. This is that wait state. This wait is at AV node. So during this wait state, what is happening? Left ventricle is filling. Now, when the left ventricle is filling for such a long time, so the pressure starts mounting and it has got thick musculature, so then it contracts. So this is the nature's mechanism. That power, it throws the blood into the aorta because it is supposed to send the blood to head, neck, brain, and on the way to the rest of the organs. So that's the whole idea. So it is this AV node, and then by the time it knows that now left ventricle is filled, it starts the another signal which goes into bundle of X and further. So this is the mechanism. Over here, we were understanding two things, that there are two circulations which we'll be dealing with: systemic circulation, the pulmonary circulation. So I hope this part is crystal clear. Now, whenever in our entire body, think it like that everyone is like doing their job. Everyone is doing their job. Heart is doing its job. What is its job? Pump the blood. But can it take the oxygen from it? No, it cannot. Right? Heart is like a cashier. Heart is like a cashier. Similarly, here are the lungs. Lungs are doing what's their work? They say that lungs, their function is oxygen, carbon dioxide exchange. There are even other functions also, but we'll talk about it later. Like how the antibodies they come, which we talked about it, in fact, surfactant. But let's keep just one function. So can lungs take this oxygen? There are my tissues. So can I take? Again, the lungs, they are like cashier from different bank. They cannot take. So how will they survive? So for them, they say that you will be given your pay. You will be given your pay. So you are on pay scale. So their salary would be. So the heart will give you the salary, and lungs will also be giving you the salary. You just keep on doing the assigned work, and that salary is, in case of heart, is the coronary circulation, coronary arteries and coronary veins. But right now, just let's write coronary circulation. Just in a minute, we'll talk more about it. And for the lungs, it will say I'll send special arteries for you, because they will be called as the, very rightly, bronchial artery, and that's why it will also call it the bronchial circulation. So what they will be doing, they will be giving oxygen to lungs, and they will be giving oxygen to heart. Oxygen to heart, to chalo, it's a good logic. Oxygen to lungs, yes, because that's the alveoli, and these are the endothelium. Right? And then since beginning we are telling yes, there will be capillaries on the way. These will be the capillaries, and these capillaries, they are coming out from the aorta, and then these are dividing into capillaries. Then they will be taking the oxygen, right? They will be having oxygen. Sorry, they will be like oxygen here. We go from here. This is the carbon dioxide which will be picked up, and that's how things will keep on going in case of pulmonary circulation. And if this thing is happening, the tissues, this alveoli, they are getting, but then this alveoli, it will say that this oxygen which person is breathing, I'm not getting anything out. So then how my tissues would survive? The alveolar tissue, right? How those alveolar tissues would survive. That's where this bronchial circulation comes into picture. So it means when we say broncho-vascular markings in the X-rays, when we say, and we call it as BVM, broncho-vascular markings. So they are comprising of what? They are comprising of pulmonary vessels, they are comprising of bronchial vessels, and they are comprising of bronchioles. The way, in case of heart, because the blood is directly given to those muscles, so it is understandable. We understand that yes, coronary circulation, we hear also that in case if heart is not getting the sufficient oxygen, then heart muscle dies, and that is what we call as the myo. Myo means muscle. This is cardiac. Cardia is the heart, and infarction is lack of blood. So that is what is called as the heart attack, and it is so popular because it is easy to understand. समझ आता है that yes, this is the coronary circulation in which the oxygen will be going, and it will be giving to muscles, and muscles will keep on working. Makes sense? But no one gives importance to this bronchial circulation. It's a छोटी सी artery, right? Their lungs, they are so efficient that they take very small amount of blood as their salary and they keep on doing this. But these are the things which you see at the hilum. Hilum is what? If this is the lung, if this is the lung, so then over here, this area is called as the hilum. So what is going in and what is coming out? Pulmonary vessels, pulmonary artery, pulmonary veins, bronchial artery, bronchial veins, and the bronchioles. That is the entire group which will be going inside and will be discharged. So this is pulmonary vessels, that is its job, and bronchial vessels, that is its salary. So far clear? We add one more step. All good? Which last topic? Tell me the point, because there is so much of ground to be covered. So much. Just tell me the point. It is not so that please repeat the whole topic. Not the whole topic. Tell me where is the trouble? From hilum. Okay. The spelling of hilum is H-I-L-U. Hilum. So here is the hilum. So that's the lung. This is the another lung, correct? Huh. And this is the area what is called the hilum. Let me just fast forward. Yes. Don't worry about what's the pathology, right? Just look at this hilum. Look at this hilum. Do you really feel it that yes, there are much more structures over here and here as compared to rest of the lungs, right? You watch for any other. See, this is hilum, so wonderful, right? It is going. See over here, going, right? So that's the hilar area or the hilum. See this one, right? A big, right? Very zoomed. So that's why we see it very properly that this is the hilum. Here it is, very nice. Here, absolutely crystal clear. Now these are different X-rays. See that. So in hilum, from the trachea, first thing comes is the trachea. So that trachea divides and it goes to primary and the secondary bronchioles. That part is good. So this part is not a problem. So there will be bronchioles. They will divide. The bronchial vessels, where the bronchial vessels are. Pulmonary vessels is crystal clear that there is aorta. There is aorta. And that aorta is giving branches, right? And these branches, they will be up. Aorta. This is where what will be going in? This will be like pulmonary arteries, right? They will be going. So this is the pulmonary trunk, and then they are dividing, right? And they will be going to respective lungs. So this is the pulmonary trunk, and then this is the right, and this is the left pulmonary artery, and they will be going to the lungs via hilum. Right? This is for their job. Their job is gas exchange, oxygen, CO2 exchange. So that job is done. So those vessels, they will be entering. Those vessels. So this is pulmonary arteries. Now pulmonary arteries, they are not having pulmonary arteries, they are not having oxygen, but they are having what? These are the pulmonary arteries which are coming from the right ventricle, right? So that's why they are having carbon dioxide. They are having carbon dioxide. Sense, right? We are talking about this part. See this part, pulmonary trunk, and it goes into the lungs. Over here is coming from the right ventricle. Got it? Right? So in alveoli, it's here. that is what really happens in the alveoli. Gas exchange occurs. So these pulmonary arteries then they will be good for gas exchange. The extra thing which we have added is this. That extra thing is that this lung tissue will also get the oxygen. You know? So for that, there comes the aorta, and aorta will give a branch which will go inside on both the sides. And that thing is called as the bronchial artery. Bronchial artery. And this bronchial artery will be doing what? Will be doing there. Will be doing salary to the lungs. That is oxygen to the lungs. So this is what really happens. And that's why at high lung, you get combination of. But simply speaking, remember it, bronchial vessels, they are like salary. They will be giving what? They will be giving oxygen to the bronchial, oxygen to the lung tissue. Oxygen will be given. Pulmonary vessels will be having what? Pulmonary vessels, they are for gas exchange. Right? It is their job. From that job, they cannot take it. The salary from which they will be taking everything and they will be surviving. So this part is clear. Pulmonary arteries enter both left and right, obviously. Pulmonary trunk, I do it over here. This is the pulmonary trunk. Pulmonary trunk divides into right pulmonary artery and the left pulmonary artery. Right? Left pulmonary artery and the right pulmonary artery. Left goes to left lung, right goes to right lung. Done. Okay. The next one. From where are they coming up? From where are they coming? In both the cases, when we talk about whether it is coronary circulation or it is the bronchial circulation, both these organs, they are so important. So they should be getting the first class of oxygen. They can't have some bacha kucha oxygen from some vessels. They say, no, we want absolutely finest of the oxygen so that we can work well. So then only one artery, and that is aorta. So aorta would say, no worries, here it is. As I am going to supply the body, right from the beginning, you just take the blood. So there are aortic sinuses which are emerging right from the root of the aorta. Absolutely. So that's where that aortic sinus, that goes into the form of coronary circulation. So when we'll be studying circulation, we find that when we look from the top, this is the aorta. Right? So then right from the root, these emerge. Right? And that's how we'll be going into the left and the right coronary arteries. And then they will be combining and they become right coronary artery, left coronary artery. Then later on we'll see that it is the left coronary artery, right? Left coronary artery goes like this, and then this goes like this. It's called as the left circumflex. This left coronary artery gives one branch, what is called as a septal branch. And the septal branch is the branch which is supplying, if I really draw it, like this, you would appreciate that it is this part, the septum. This septum is very important, right? Because it is between right ventricle and left. This septal branch supplies entire 2/3 of this portion, septal branch, which is emerging from this left coronary artery. So if anything goes wrong to this artery, it will lead to problem in the left ventricle and the septum. They both are affected. When they both are affected, rest of the heart, even if it is fine, but heart won't be able to pump the blood into the entire body. Entire body tells no worries, will compensate, but brain would say no, I can't. So, and in brain, it is the respiratory center. Which is most vulnerable. everything. This is, so this is midbrain, and the pons medulla. In medulla, there is a respiratory center, and this respiratory center is most vulnerable to hypoxia. Hypoxia means the lack of oxygen. So when this thing occurs, this is the first center which dies. Rest of the entire body is fine, but this center dies. And if this center dies, this is our respiratory center, which is going for that automated respiration. That thing stops. Right? Then you put this person on ventilator for any amount of time, nothing can be done. Practically nothing can be done. So that's the reason that for the aorta, it is a very crucial work. I'm coming to that. So that's why it is such a crucial work. So from aorta, there goes the coronary arteries, and then they will supply, then there will be formation of coronary veins, and finally they all will be similarly about the lungs, right? Here is the aorta. From aorta, there would be the bronchial arteries. They will distribute, right? They will distribute, they will give the oxygen. Here also they will give the oxygen. And then these bronchial veins, they'll be having CO2, right? And this bronchial vein, we feel like, no, it should really go back to the lungs. No, to go back to aorta. This is the thing, to go back to aorta. So it means this particular aorta, when it carries the blood further, it will be having some carbon dioxide. Which was given by the lungs. But the amount of carbon dioxide is very less. It is very less. So the majority of the oxygen, that is what is gracefully carried out for the rest of the body. What I really wanted to express is that heart and the lungs, you need to give them the best material, best oxygen immediately, because they both are very delicate. Today, when we'll be watching that, what is the damage, how the lungs can really get damaged. You see those damaged pictures. You have seen sufficient normal X-rays. Today, when we'll see those pictures, we'll come to know that such things can happen. So that is our today's purpose. Okay. So in general, what we in nutshell, what we really understand is when we talk about the pulmonary circulation, this is a low pressure system. And it makes sense also that it has to be a low pressure system because alveoli, they are very delicate. Actually, we need to protect those tissues, otherwise unnecessarily they break. Second, if you really look at the length, the pulmonary trunk, and then that pulmonary trunk is dividing into left and right pulmonary arteries, and how far are they? Immediate. So this is a small system. They don't have to travel much because just at the distance of 6 inches, both the lungs are there. Lungs, they give those pulmonary veins, and those pulmonary veins, again, the heart is sitting right in the middle. Immediately they will drain it. So it is a small system, right? It's a very small system. What about the systemic one? Right? Systemic circulation. It is a huge system, big one, right? And the amount of thrust, the power, the pressure with which it has to pump the blood all the way up and down, right? Especially perfusion to the brain. And because brain tissues, they are always hungry for oxygen. They consume more than half of the oxygen, though that is consumed by the brain only. Because the metabolism, that is super fast. So over here, when it is a low pressure system, why this is a high pressure system, right? And we saw the pressure of high pressure system. If this is we consider as the small system, then definitely systemic is a large system. Large system. Right? The third important thing is that when we talk about the blood which is circulating, this is about the hemodynamics. Hemodynamics will be one topic that if you master it, then respiratory system, cardiac system, the entire vascular system, that will become very easy. Hemodynamics, the blood, the dynamics of blood, how the blood is going, right? Now this is where you have to visualize that it is the same blood which is rotating, same blood, correct? It is not so that when the blood is pushed, right, so it is 5.5 liter and then only 2 liter blood is returned. That happens, so then where is rest of the blood? Right? Such situations occur. But that thing, stop these messages. Who took admission in Georgia, etc. This is not the place for any of such discussions, because otherwise I'll ban you. Right? Stop it. This is focused only on studies. And any of the discussions you want to do that, do it with your consultants, right? Not over here. Don't play any of the politics and any of the things over here. Right? I never tolerated even 0.5%. Is that clear? So don't force me to ban anything. Okay, coming back to this. So it is not so that for the when the blood is getting pushed, right? When the blood is getting pushed, it is 5.5 liter, and when it is coming back, it is 3 liter, 4 liter. No, it cannot be like that. Right? The same amount of blood is going and coming. In some situation, when there is peripheral pooling means those capillaries, they are holding so much of blood. So in that case, less blood is into circulation because it is, I'll explain it like this. This is a small tank of 1 liter, and you are pushing 5 liters from here, and the 5 liters is coming back, right? So this 1 liter will remain there, right? It is the blood which is. No, I'm not telling you. I'm not telling you. Well, send a mail when for any of these issues, right? Because my focus, otherwise it would be deviated to other topics, right? What you are writing. Any of the problem, any of the things, send a mail. Not over here. Over here, only things which are related to our subject. Now I'll tell you what is there. So just think it like this is 1 liter. So if we have got total, right? The total 5 liter, then can I say that this would be the 4 liter? Because it is the 4 liter blood which is into this circulation. 1 liter will remain over here only, and here also this is the 4 liter. As such, 5 liter blood is getting pushed and received. But this 1 liter, it will remain into that tank, right? It will remain into that tank. So if it's this 1 liter, it will be pushed. Naya 1 liter will take its place. Right? So the rotation is of 5 liter, but this 1 liter is lying over here only. So if anyone is getting some oxygen from here, so it is only 4 liter which is working. Now what if this pool becomes bigger? We make a big tank. Now the tank is this big, right? And this tank has got capacity of 2 liters. 2 liters. The tank has got 2 liters capacity, but the amount of blood is the same. So then effective blood which is now into the circulation, that is how much? 3 liters. Right? It's 3 liters because 2 liter blood is remaining into that pool, that tank. This is what is called as the peripheral pooling. Peripheral pooling means when the blood is getting circulated, right? If the hand is right, there is huge swelling, right? So the blood is getting pooled into all these areas. So this is the real blood, right? The same blood what is into the circulation. But because that blood is stopping over here, So this acts like a tank. When it acts like a tank, there will be less blood into the circulation, and that will cause all those problematic things, right, which we'll be discussing in detail, just in detail. But this is how it really happens. Peripheral pooling. Peripheral means whenever we talk about peripheral vasculature, does not mean the other later was kept from the blood which is being put. That's right. The extra blood, it is lying over here, and it actually happens, right? No, it is pool, swimming pool, right? Swimming pool. There is no one pulling, right? It's swimming pool. Think it like swimming pool, right? Whenever we use the word pool, pool means accumulation. Pool means, I'll not erase this image. It is called as accumulation. And what I was talking was, whenever we use the word peripheral, peripheral means all the deep areas or the terminal areas, right? All the capillary areas. It's the flood situation. Such heavy rains. There would be the cloud burst. Okay, so that is, so over here, what I was telling was the same blood which is coming, right, in the going, the amount is same. One system is large, one system is small. So will there be change in the speed? Forget about the human body. Think it like this is A, this is B. This path is 10 kilometers. This path is 5 kilometers. And the amount of time which you take going from here to here and the amount of time which you take from going from here to here, that should be the same. So will there be any change in the speed? What? Who will be the faster? Akshat? Think again. Arey, over here, say both of them, if they are completing, let's take it this way. Now you are right. Now you are right. Because all those answers, like 5 kilometer pulmonary system, take it that way. In both the cases, you have got, say, 1 hour. You have got 1 hour. In 1 hour, you are supposed to cover this distance. If this is the distance from A to B and you have to really cover 10 kilometers, then you have to run at a marathon speed, right? You have to really run, because then and then you will be able to cover the distance. When it is B to A, 5 kilometers, simple walk is enough, because the distance is less, correct? So this is why the systemic circulation, and second thing, in systemic circulation, you will agree to that if you take the pulse is like right? Such powerful pulse. So that is the systemic circulation, because when we'll be studying the medicine, we'll see that at times you have to coordinate with your carotid pulse. Because why carotid? Because carotid is coming out of this arch, right? It is like common carotid, right? And then it gets divided. But it is this left common carotid, and over here, it would be the right common carotid. But they are in direct touch with the aorta, and aorta is in direct touch with left ventricle. So the pressure transmitted is immediate. So that is when we get that powerful pulse. When you will see, when you will dissect, when you will be watching it in anatomy, you will find that these pulmonary vessels, they are so najuk, very thin walled. And even when I'll show you the CT section, CT, MRI, you will see that the bore or the caliber or the thickness of this aorta, they are so big as compared to this. Superb question, Sakshi. Right? I'll take this question. Just give me a minute. So, sorry, I lost the link. What I was talking. Estimate and explaining something. What I was explaining, I'm sorry. I just lost the link because your question was good. So immediately I started thinking of. Now, so they don't have to handle the pressure. They don't have to handle the speed. So then why should they be thick? Thickness increases as they work out. So aorta is working out right from the beginning. So that's why all the systemic vessels, they will be thick walled, thick walled. And again in that, arteries, as they are having more pressure, so arteries will be thicker than the veins. Two. Acha. Why doesn't the concept of small the area, more the pressure applies here? This is who asked this question. This is why I said that this is Such a good question, because in this question lies the pathology of almost entire respiratory system. Seriously, in just this one question. That why it happened? Yes, the logic is true. If this is a big chamber, so in that the amount of blood is same amount of blood is into this Choda chamber. But here, obviously the pressure should be higher. Totally agree. But what happens over here? That it is these capillaries. These capillaries, they are not like dead tubes. These capillaries, right? These systems, they are having smooth muscles. Correct? They are having smooth muscles. So if I cut one capillary, is this? So they'll be having layer of those smooth muscles. Smooth muscles. So when these muscles they contract, what would happen? And when they contract to the caliber or the bore of this particular vessel, it will become small, right? So it means who will be experiencing the pressure, right? This remove this. Right? Now, let's say if this size has become smaller, then who will be experiencing the pressure? Obviously, this systemic one, right? So they will be experiencing the pressure. Right? It is this pressure. It is this pressure because of the capillary system. It's this pressure because of the capillary system that is generating what's called as the peripheral resistance. Again, using the word peripheral. It is exactly like a dam, right? Dam takes the entire pressure. Right? Over here, when today they said that this is the dam and they have opened 23 doors, right? That means now the water is really falling out of this dam with such a power. But is this power equal to the power of dam? No, the dam is under tremendous power because that is the entire load. And then only a small portion is open, a gate is open, and the water starts flowing into. As this water trickles further, it will be having very less pressure as compared to the amount of pressure which is into the dam. Same thing happens over here because it is not one capillary. There are millions of capillaries. So they'll be giving resistance to that side, right? From where the pressure is, the high pressure system. And then when it goes out, right, so the pressure is decreased. See this? See this? The amount of pressure which is over here, it is 120 by 80. But post capillaries, the pressure over here drops to 2 mm. Absolutely less. And it is this low pressure system, that thing is maintained all the way. The pressure is once again built at left ventricle. Right? So even though this pulmonary system is a smaller system, but due to the presence of this small circuit, right, it is giving this system, right, the low pressure system. Got it? Right? Because it is a continuous process. So under high pressure it comes, then that pressure slows down, right? That pressure decreases, and they trickle comfortably. Then once again, when they come to left ventricle, where left ventricle contracts, again it is pushed. But that entire push is eaten by those capillaries. So this is the resistance. This is the area of resistance. And it is this resistance which will be making a big change. That's what we'll discuss. Which will be making a big change when you give ACE inhibitors. These are the type of medicines which you give to your blood pressure patient. Right? So this is the point. This is a very good point. That's the point where it is said that once you understand the capillaries, this is not 1 or 2 or 5 or 10 or 100 or 1,000 capillaries, there are millions spread across the entire body. This is the reason why the skin is considered as one organ. We do have lungs, but it is skin also. So Man with the Golden Gun, James Bond, in which that heroine was killed. by applying the gold paint on her entire body. That was the movie, but it was scientific. If someone is painted with the paint which is not allowing to breathe, so then person will die. Right? Skin is one of the very important breathing apparatus. But because all the capillaries are there. These capillaries, they are taking care of so many functions. So one of the function is like this, is giving resistance to the blood which is coming up. Over here, it will give the resistance so that blood slows down. It gives oxygen, right? And the carbon dioxide is taken and then it moves further. Over here, smaller circuit, and we need to transfer oxygen and gas, right? So that's why it is much better when it goes slowly. Aram se it takes oxygen, carbon dioxide, low pressure system, because if the pressure is high, so then that high pressure of the blood that will penetrate through the alveoli and it will be leading to the pulmonary edema. This is what we talked about, right? It will lead to that pulmonary edema, and the fluid will go into the alveoli. Now I take you to one more interesting concept. Something which is considered as extremely complex, the blood pressure regulation. So, as if I'm preparing you for that topic. Amongst so many features of the functions of the alveolar system, right? Gas exchange. But one very important feature is the blood pressure regulation. Now, if it is theory, so then we can say that this blood pressure regulation, that is over here, this is the alveoli. That is called as the angiotensin converting enzyme, ACE. That is the angiotensin converting enzyme, which is boring because this has not appealed much. Let's understand it slightly. This angiotensin, see, such a beautiful name. Angio means vessels. Tensin is, it makes them tense. Right? It makes them tense. So vessels, and these vessels are made tense. So basically, this angiotensin is a peptide hormone. It is a peptide hormone. That means it will be made up of amino acids, right? And its function is one, as we say, the blood pressure regulation. But there is another very beautiful function, the fluid balance. The fluid balance. Whenever you learn blood pressure, never learn the blood pressure as a separate topic and the fluid balance as then another topic. They both are so closely associated. So that's why we are spending few minutes on this. Though this thing will be coming in amazing detail when we'll be talking about renin-angiotensin system. Renin-angiotensin system will come in kidneys, it will come in liver, and it is coming over here. And it will come in pharmacology also, it will come in pathology also, right? Everywhere it will come. So that's why I'll be going slightly deeper into that. So blood pressure regulation and fluid balance, we'll take both the things together. Yes, RAS mechanism, renin-angiotensin system. Renin-angiotensin aldosterone system. That's right. That is what we'll take. So if you know it very well, right? But still, then this one would be a sort of revision. So there are four forms of angiotensin. They are said as type 1, type 2, type 3, and the type 4. Out of which 2 is most important. That is actually the active one. For any of these formations, there is always a precursor. Precursor means what? Precursor is something from where the things start. The basic raw material. And this raw material is produced by the liver. Right? So, liver produces angiotensinogen. Whenever the word gen comes, that means just understand that it is a precursor. The journey would start from this point, and then it is released into the blood. The liver has done its function. So in case if anything goes wrong to liver, angiotensinogen is not produced. Khatam, right? The problem right from the beginning. Alcohol, yes, it affects liver and it affects this angiotensinogen. That's why Amitabh Bachchan said, "Daru pine se liver kharab hota hai." So that is true. So then comes the kidneys. Right? As the blood is passing through, kidneys will watch. So kidneys will what is called as the planning. It is by kidneys. Again, if anything goes wrong to the kidney, so then this angiotensinogen will not be converted into angiotensin 1. Trouble. This angiotensin 1 would be converted into angiotensin 2. Angiotensin 2, and this angiotensin 2 is by lungs. Right? So here is the lungs. So what lungs are doing? Lungs would say that in my alveoli, those endothelial cells are there. They will be releasing one enzyme, and that enzyme is called as ACE, angiotensin, such easy name, right? Angiotensin converting enzyme, right? How easy it is, right? Just it is a joint venture of liver, kidney, and lungs. Now it would be say much more clear that it is the liver, it is the kidney, it is the lungs. All of them, they have got the role in blood pressure. But where is the blood pressure? It is this angiotensin 2, who has got some very important functions, 4 major functions. In fact, four functions. If you understand these functions, within next 5 minutes, you'll be understanding pharmacology, pathology. You'll be telling that these are the drugs to be given. Everything will become so easy. Not only that, we'll be able to say even the side effects of these drugs, all of them. Right? So let's start with it. 4 functions. First function. What was the name? Angiotensin. It tense the vessels. So a good name. Vaso means vessels. They tense them, so that means they constrict them. So it is vasoconstriction. When the vasoconstriction, big road is there, and when that road is made narrow, so automatically the traffic would be increased, right? Because now the same number of, say, cars they were same, but less space, so there will be dhakka. Same thing happens over here. And blood pressure is what? Blood pressure is, this is the vessel, the amount of pressure which is generated onto the side walls, that is called as blood pressure. So previously there was bigger area, now there is lesser area, so the pressure will be more. So this is blood pressure. This is easy, right? Vasoconstriction. First thing. The second, this angiotensin goes and it will go to adrenal glands. Those adrenal glands, they were sleeping comfortably, and it will go over there and we stimulate them. Chalo, do some work. So they will release what's called as the aldosterone. Right? Name is like monster, right? Very powerful name, aldosterone. This aldosterone, it is like a Hitler. It will say that kidneys, the sodium and water, right? The way they gundas, they say ki apna aadmi hai, right? The same way this aldosterone will say that they should not go, right? Take them back. So kidney would say that, "Arey, sodium and water, this is my duty, nothing to do." Aldosterone is the big boss. So there is massive sodium and water retention. Sodium and water retention. Sodium is not allowed to go, water is not allowed to go. Now you know the sodium potassium pump. Right? What would happen because of this? Because of so much of water, right? There will be swelling. Right? There will be swelling. But it's say we don't care. Blood pressure should be increased. Right? Still, if it was less, see how influential this angiotensin. Angiotensin will go up. It will stimulate the pituitary. Right? It will tell the pituitary that yaar aap kuch karo na. Pituitary will release what is called as the ADH, anti-diuretic hormone. Right? Diuresis is when the water is to be passed on into the urine. This is ulta, anti-diuretic hormone. So this will also go to kidney. Are you crazy? Don't throw the water in back. So water reabsorption. Water reabsorption. So when the water is getting reabsorbed, sodium and water, they are also not allowed to go, right? And on top of it goes to, as it is going to brain, so it will go to the neighbor also. Right? It will go to hypothalamus. It will go to hypothalamus. And it will say that they are आपके पास तो कितने अच्छे सेंटर. There is the thirst center. Right? There is a center for salt craving. So it will go and it will stimulate. So the person would be tempted to drink. Right? So again, the water has entered. Finally, what has really happened? The entire pool, the water into the body has increased. And the first point, this is vasoconstriction. The roads have become narrowed and number of cars have increased. So obviously the traffic has increased, the pressure has increased, the blood pressure is bound to go up. Blood pressure will go up. How smart. But then there is one amazing system of the body. If they keep on doing this thing, right? So there is something like ACE inhibitor. Right? They are called as the ACE inhibitor. So when the blood pressure is high, in such cases, when the blood pressure is high, so the treatment would be ACE inhibitor. What would happen in case of ACE inhibitor? It is this. Just block this. It is the angiotensin 2 which is powerful now. It is the angiotensin 2 is playing all these games now. Isko hi maro. Don't, and this angiotensin 1 is very sharp, right? It won't do anything. But it's angiotensin 2, that is who is playing. So, and who is converting it? This is to inhibit the ACE. Angiotensin converting enzyme, this enzyme, what if we stop this enzyme? So this is what it will be done. So ACE inhibitor. So these ACE inhibitors, these are the specific drugs. Very easy to remember these drugs. Their name will always end with prel. The name will always be ending with prel. The commonest drugs which are like, say, benazoprel, or captopril. Very common things, right? Then like, say, this enalapril. But everyone will be ending with pril. This means what they will be doing, this is angiotensin 1, which is getting converted to angiotensin 2, and this is by ACE, angiotensin converting enzyme, in endothelium of the lungs. Lock it. Don't let this ACE go out. So that's it. Now angiotensin 2 will not be converted, right? Will not be formed. So where will we be using it? We'll be using it, one, in case of high blood pressure. when the blood pressure is high, we use it. Where else can it be used? High blood pressure, if the pressure is more, so that will be like, it will convert it to, will prevent it to convert. It will prevent it to convert, right? So it will be angiotensin 1 will not be converted to angiotensin because it is the angiotensin 2 who is the vasoconstrictor, who is affecting the aldosterone, right? Who is affecting the brain, pituitary, hypothalamus, everywhere. So we just catch hold of the root. We stop him only. So that no natak is done by him at any of the level. Right? So now when the heart failure is there, the vichara heart is weak, and on top of it, such system is putting the pressure. Right? Similarly, the kidneys. In case of chronic kidney disease, you can give this kidney disease. What would be the logic in case of chronic kidney disease? Why are we giving ACE inhibitors in case of kidney disease? Why? ACE inhibitors, यहाँ पे तो logic बनता है, right? This decreasing the blood pressure. In case of heart failure also there is one another logic, but antidiuretic hormone stop reabsorption. That's not good. And anything more? It won't stop reabsorption. Okay. It will let it go. It will let it go. Because the reabsorption was right here. It was getting, that was water was getting reabsorbed. So it was, it stops reabsorption. Okay. Now I got it. That was one. Now it is. So, see, in kidney disease, what happens? Bishari kidneys as such weak. Right? And if the body is keeping water and the sodium and water, right, if they are kept, so then unnecessarily it will be causing harm to the body. When we give ACE inhibitors, so this thing is allowed to go. It is allowed to go. And this will be having a good effect on it. So that weak kidney, even it will work to its reasonable efficiency and it will let the body release. And another thing is when the kidney disease is there, so there would be the high blood pressure, then that also will come. So similarly, this heart failure. When we let the sodium go, because it is the sodium which can cause so many cardiac arrhythmias, right? So we want that sodium should go. Because sodium is not good for our body. Sodium is not good for our body. So that's why in all these cases, ACE inhibitors, they are allowing that sodium goes, water goes, right? So they are making the system light. Aldosterone secretion is affected. So all those things, that is how we are doing oxygen. Okay. Still, there are so many other things also to discuss, but we'll take it next time. Next time we'll pick up from this point of view, because I wanted to discuss at length the all those natriuretic factors, etc. Even the second most important component, that is the bradykinin. Right? When the bradykinin comes into picture, then the story becomes still more interesting. But we'll take it next time. Thank you. So let's see those X-rays, some of the good X-rays which are to be. Next time, this topic would continue. Here comes the first X-ray. This particular X-ray. What do we see in this case? The first impression. Can you see the first impression that entire bronchovascular marking is very prominent? Very prominent. Very prominent. Can I write BVM or should I write full one? So once I write full. So bronchovascular markings. They are very prominent. You are watching it almost till the end, and they are thick, coarse, and see so rough. This is the case of bronchiectasis. Is it white line? Good that you pointed out. Then you see one device, then there is a tube. This tube is going over the way. This is one of the methods. This is what is called as the Quota gap. It's called a Quota. This is one of the methods by which you can administer the drugs directly into the system. So it is like permanently placed. That's how. Two other things which are to be seen in this case. Can you see this portion? This portion is whitish. Consolidation. Markings, these are the markings. These are the markings what you are watching. That's straight the normal look. When you compare it with your normal X-rays, you find it that yes, they are very coarse, very rough. Otherwise, lungs look very delicate. Coming to this is consolidation. Consolidation. What we learned last time. Which lobe? It is not that lobe is not fully occupied. That's okay. Right. This is the right lower lobe, not fully involved because we are watching this diaphragm here. So it is not so that it is fully involved. That's right. This is the lower, right, lower. Good. Shabash. Watch this. Watch this. This is like a test. Watch the full one. Now it is perfect. You can see all the findings. Quota cath is a tube which is put into it, right, for the transfer of drugs. Gentlemen, she is a female. That's not the diagnosis. What is the diagnosis? Something which we discussed at length last time. At length. If you have revised those X-rays, good. Yes, Desya. Write down the reason for it. What you wrote is correct, but try to write down the reason, not by the visuals, the scientific reason. Which shadows are we talking about? Which shadows are parallel like? No, I'm not getting you. Are you talking about these? These? Which shadow? Yes, Tanvi, you are right. What has really happened is you are giving the partial detail, give the complete thing. On steroids, bone density is so pretty well. Bone density is quite good, very nicely seen. That person, Aditya, that particular patient was on steroid. That was just a coincidence, right? When the bone density was less. Forget about that. Something which is so striking. Look at, I'm giving you the hint, mid-clavicular line. This is the first, this is the second, this is the third, that's the fourth. Here it is the fifth, here it is the sixth, here it is the seventh, here it is the eighth. Just this much is sufficient. Because when we draw this line, this is the diaphragm. Diaphragm is at the level of 8th. Itna niche. Normally, it should be between 5th to 7th. Anterior end of ribs. 100%. The lungs are hyperinflated. So this is the thing. In this occurs when the patient is trying to breathe with so much of trouble. This is a case of COPD, and we are watching towards the hyper expanded lungs. Absolutely fine. So on the opposite side also, we can calculate the ribs. Right, here it is. Right, here is the first rib. Here is the second one. This one is the third. This one is the fourth. This one is the fifth. This one is the sixth. This one is the seventh. This one is the eighth. And this one is the ninth, right? So definitely, this is like dome of the diaphragm. Their normal shape is like this. So yes, what finding which you wrote, flattened diaphragm. Flattened diaphragm. Completely agree. Right, so this one is on both the sides. This is, though it is not a radiology exam, but still I was a bit tempted to show you this particular image. Doesn't it look like that this is the heart, and this bichara heart is floating in air? Diaphragm ka to koi support hi nahi. Here is the diaphragm, here is the diaphragm. So this particular thing, when you saw it, when the lungs are hyper expanded, this is called as the floating heart sign. It's called as the floating heart sign. When the diaphragms, they are flattened, they are so low, and as if the heart is just, this is typical. And how do you say that scientifically? When you really can see the lower border of the heart very clearly. Say this is the lower border of the heart, is seen so beautifully. Normally try to see that. In case of normal heart, right? Over here, see, the heart is this, right? We are not watching that. It would be here, but we are not watching it. It is not that. Over here, if you calculate, it is falling into the range. The size of the lungs, it is normal. But in this case, yes, we are watching the lower border. Because there is a space which has been created, and that's why it is called as the floating heart sign. Right? You remember it. I'll not insist on the diagnosis. Just if I draw a line, what is the difference between this upper half and the lower? Baki sab chhod. Forget about the diagnosis, forget about everything. Just train your eyes. Right? Okay, I'll keep the line. Color, because color to mujhe dikh hi mega, it is all black and white. Yes, who has answered this? Someone answered it. Just for few seconds, just do the message. That's right. Upper half has more air, and Shida, what you said, upper half is more dark. I agree with that also. Then bronchiolitis are seen clearly. Itis, whenever the itis comes, that means inflammation. So you can say bronchioles, they are seen clearly, or the bronchovascular markings. The best answer, is BVM, or the bronchovascular markings, but it doesn't matter. Lower half is denser. And then opacity, I mean, you need to, where lower region looks consolidated. Okay. Region. Put a query. Huh? Sorry. So because it is like glass is half full or half empty. है ना? Glass is half full or half empty. You say that this lower region is consolidated, and there were few answers that this upper region is looking dark. Well, that is apparent. And as we discussed that whenever it is dark, that means there is more air. That is what we are discussing right from the beginning, and it is true even for the X-rays. The amount of X-rays which will be crossing, if it is only air, there will be more as compared to the amount of tissues when it has to pass. Over here also I'm putting query. So hilum, monolithic hilum, write more. What do you mean by hilum? I mean hilum is this, but what? Upper part is more dark, yes. Aditya, consolidation where? Kahan pe? Be specific. Vedant, upper one seems to be clear, means it has more concentration of air. You are right. Bottom part is more whiter than upper part. Yes, Hans, yeah, that is right. Is it fluid filled? Well, fluid is not there because you have nothing. You have seen the fluid, right? When it is fluid, the fluid it really obscures everything. Right? Last time, if you remember, when we saw one X-ray of pleural effusion. In pleural effusion, remember when there is fluid now, so that fluid kahan pe bharta hai? Where it fills? It gets filled into the alveoli. So when the alveoli are filled with fluid, so then air is thrown out. There is no scope of air. When there is pleural effusion, that means you won't be watching any of the BVMs because we just watch the air. So when the air bronchograms are not seen, so we can say here the air bronchograms, they are seen must, right? Ekdam first class. So pleural effusion, it won't be. Hilum is relatively lower. No, it is okay. Hilum, bronchi are less in upper side. Well, just change it. Bronchi are seen less, right? As such, so they are there. Air accumulated in the darker part. Agreed. Right lower lobe is consolidated, so not clear. Okay, I put the query. We'll just talk about it. Achha. Now let's solve this. See this particular image. If you really watch very closely, this part. Are there any bronchovascular markings? Truly speaking, there are no bronchovascular markings. Right? Everything has thinned out. Here there is so much of air collection. Right? Darker means more air. Very right. So there is more air collection. And now I'll unzoom it because some things, when we see the X-rays, right, when you try to see it from very near, you might not see it. But when you see it at a distance, suddenly the whole thing appears clearly. So using the same technique, watch this. Do you really find that amongst this entire thing, there is one very black area in this? See again. Are you getting it? There is one round, big black area. As compared to this entire structure, right? This one is very black. Is having more air is a good sign. Right now, don't worry about good sign, bad sign. Just can you appreciate this? Then I'll come to that. Do you see that? If you can see this, that yes, if your eyes, they can appreciate the difference. Yes, this part is more black as compared to this. This is definitely white. This is this portion, which is called as the bulla. Trapped air. Right? Trapped air. This is what is called as the bulla formation. In cases of chronic obstructive pulmonary disease, you will find such trapped air into many of the areas. This lower region is in fact completely normal. Why it is looking white is because of the female breast tissue. So over here, because of the breast tissue, right, this is becoming more whiter because that tissue is there. So amount of X-rays which will be passing through it, they will be relatively less. As such, everything is normal, right? Over here, so because of that contrast, right, these are looking more prominent. But there is nothing like, say, this sort of pattern. See this, the well-marked whitish pattern. That is not there. But here, like see this one. This one is typical, consolidated. So it is not there. And more or less, it is towards the periphery. So it is like the lower region should have more like say none. It varies from the person to person. Over here, if the breast tissue is more, so sometimes you'll be getting such whitish shading because the amount of X-rays which will be passing through the tissue will be less. But this one should not miss that this is like a encapsulated space. See the next X-ray. It is still more better. See this. This area, right? This area. Over here, so if I zoom it, there is how wonderfully you can see the encapsulated. Yes. This is outlined, clear outlined bulla. All these, whenever you see the bulla, they are part of this. This very fantastic X-ray. Usually this is not seen much, but the size of the bulla. See this. See this. See the clear boundary. They are more dark, very prominent over here. See the border. This is the. Now it is very easy. They are collected. It is harmful. Yes, when the alveoli grow, right? One alveoli, second, third, fourth grow, and it is just the air. So it is when the alveoli they keep on breaking and then they merge together. That is when this bulla formation happens. It is bad. It is like the air trap, but it is of no use. Person can't use it. So see over here, this big. Now it is very easy. This is the big bulla. This one. The differential diagnosis, it can easily be confused with pneumothorax. Right? Though at this point of time, we have not seen the pneumothorax, so I'm not telling much about it. But next time, at least we'll see 2 or 3 X-rays of pneumothorax. That is why how it happens. Because in pneumothorax, you'll be able to see over here. You can see some bronchovascular markings, right? Some markings they are seen. So over here, see BVM, they are seen. In pneumothorax, not a single bronchovascular marking is seen because the whole lung itself is pushed, right? It is pushed, and we'll be able to see the pleural margin. In this pleural margin, not seen. If this is not very clear at this point, next time it will be very clear. Then I'll show you both the X-rays together, and we'll discuss even the pneumothorax. Yeah, a very typical. This is another case. This is what is called as the watch this. The immediate findings are like, if not much, can you say that borders of the heart, they are seen, they are like extensively seen. But can you comment about the borders of the heart, right border and left border of the heart? Borders of the heart. What is your opinion on the borders of the heart? Do write some. Gas bubble and heart border, consolidation of right lower. बाकी सब छोड़ दो, बस हाँ, that's just the blurred, very blurred. Yes, this here no defined border. That's right. That's what is to be seen. That these borders, they are not clear. They are not seen well. Right? We are unable to see them. And this thing is called as the shaggy border. Shaggy border. Unclear border. Unclear border. So wait for the consolidation. This is something which is, I'm taking you step by step. So you saw about the borders. Second, tell me, the looks wise, is the heart, are the lungs normal or they are expanded? Are the lungs normal or expanded? So if we, so many answers they are coming up for the expanded. Okay. Let's check it out. This is the first phase. It's the first. That's the second. This is the third. That's the fourth. This one is the fifth. This one is the sixth. That's the model. This is midlife. So this now normal. That's right. Lung volume is normal. Never go with the judgment, you know, patient has got this much, so definitely the volume is no. No, there is no. I'm coming to that. I'm coming to that. Step by step. So this is like, these are the two major always try to find out pick up the findings. Don't try to jump on the conclusion. Because as you will start getting the findings, you'll be coming more and more near to the conclusions, right? More and more near to the diagnosis. So one thing is clear, that the border is shaggy, that is the hard border, but the lung volume is normal. Next is what you will be watching is, I'll give you this. Trachea is slightly towards the right side, but it is not much. Yes, you are right. There is minor shift of the trachea. There is, but there is something very important which is up. We learned that bronchovascular markings, they are seen only up to the medial 2/3. What is happening in this case? All the way right. Some strange patterns. Otherwise, you must have seen that this area is so crisp, clean, right? Like the must. Over here, what is this? Right? It is not at all clear. So much so it is whitish. Compare this part. So if I'm telling this is 1 and this is 2, compare the part between 1 and 2. Compare the part between this A and B. This 1 and 2. Suddenly you'll find, yes, it is happening, right? It is this area, right? It is this area. This is fibrosis. 1 and A is clearer than the rest. 1 and A, they are clear? No, they are. See, this area has to be clear. It is not clear. It's very much, this is what is called as the pulmonary fibrosis. Right? See this area, can you see? It is, when you call it clear, in fact, it is looking more dirty. Right? See this area, it is looking more dirty. Correct? So this is pulmonary fibrosis. Now, show you one more. So these here, we wrote that lung volume is normal. Now, same patient after same patient. That was 2020. This is 2022. So after 2 years. Findings. Just one. What about the fibrosis? Fibrosis. Okay. Is the lung expanded? Is the lung expanded? Said no. Why? So let's calculate. This is rib number 1. This one is 2. This one is 3. This one is, let's get here is, this is the, this. Heart is not seen. There is fibrosis, yes, very much. On both the sides, and see. But most important, telling you again and again, mid-clavicular line, and it is ending up at 4th level. You only said that the normal is 5 to 7, but the 4th pair. So now it means what? Heart is shrunken. Heart is shrunken or lungs are shrunken? So acha hai. Lungs, correct? Lungs are shrunken. Lungs are shrunken. That means the capacity of the lung has increased. Lungs are shrunken. So now if you take it on this side, lungs are expanding. Lungs are not expanding. In this case, because of fibrosis, lungs have become smaller. On left, let's calculate. This is 1, correct? This is the first rate. This one is the second rate. This one is the third rate. This one is the fourth rate. This one would be the fifth rate, right? The diaphragm is here. Where is it? Below 6. Below 6, so it is here. This is 6. See, can you see this big? This is what? This one. This one. This is what? This is what? Or you can just take this much. These are all gas bubbles. So over here, so this is the 4th. Even yes, we can take it at 5th. So over here, this is the gas bubble. Yeah. So it is at 5th. 6th would be a bit low. But even in this case, so it is definitely shut. If the lungs are shut, why? You have to compare it with the previous one. So you compare it with the previous one. Now when you have this X-ray and this X-ray, yes, shut. This one, this one 2, this is 3, this is 4, this one is 5, this one is 6, This is 7. So that is 6 to 7. And over here, it has become one rib up. It is now at the level of, say, 6th. Almost here. So this much is the loss. All right. Gas bubble is normal. Gas bubble. This is the gas bubble. This is the gastric bubble. Gastric air in the stomach. This is where the stomach is. So all right, that's it for today. Thank you so much. Yeah. It happens. Don't worry about it. All right. Send Sahil, send a mail to me. And this is the email address. Send a mail to me. I'll send you the link.
Thank you, sir.
Thank you. Okay, so take care. See you soon.